Good morning. Today we will have two short case discussion on benign breast disease. Dr. Ishita Laha is third year junior resident at Archive Share Pradishthan and Vivekananda Medical Sciences will present, and Professor Prashant Kumar Bhattacharya is Professor of Surgery at Arjigar Medical College will moderate this session today along with me. Okay. Ishita, you can share your screen and start.
Is my screen
being
visible?
Being a short case, you finish up the presentation and then you will discuss about the history and examination.
Sir, I have written it out in the pattern of a long case only. Means okay, it will be quick. It will be quick.
Okay, fine. You present.
Okay. Good morning,
because
everyone.
I agree. In DNB, there is nothing called short case. You
yes,
present like a long case only.
Yes.
Just present. Fine.
Good morning, everyone present here. I begin with Mr. Y, a 17-year-old college student, resident of Kolkata, presented with a...
Make it to slideshow.
Yes. Presented with bilateral enlargement of breast for last 1 year. On history of present illness, the patient was apparently well 1 year back when he noticed bilateral enlargement of both breasts gradually over the past 1 year, and there is no history of nipple discharge associated, no history of any pain, no history of swelling in the axilla, no history of any trauma, and no history of hepatitis or mumps orchitis, no history of any drug intake, though there is a history of increase in weight. On history of past illness, there is no significant illness, no history of exposure to tuberculosis, and no other comorbidities. Personal history, sleep, bowel, bladder, appetite are all normal, no history of any allergy to any known food or drug, and sexual function adequate. No similar disease to any other members in the family. I summarize my history as a 17-year-old presented with a bilateral enlargement of both breasts gradually over the last 1 year, and no history of rapid increase, no history of discharge from the nipple, and no other swelling in the opposite breast and axilla. So may I go ahead?
Yeah, proceed.
On my general survey, my patient is alert, conscious, and cooperative, and oriented to time.
Just a moment.
Okay.
You go back to the other slide. You said the bilateral enlargement of.
Yes, sir.
No. The last summary slide. Bilateral enlargement of both breasts.
Yes, sir.
And no other swelling in opposite breast and axilla. I mean, what?
No other swelling present means no other visible swelling present in the breast. I'm sorry, sir.
Then you should remove that word opposite.
Yes.
Isn't it?
Yes, sir.
Yeah.
Because it's an enlargement. What is an enlargement? Because of tumor or just a diffuse enlargement that will decide on examination.
Yes, sir. On my general survey, my patient is conscious, alert, and cooperative, and oriented to time, place, and person. And Karnofsky score of 100. BMI is 21, and decubitus of choice, well hydrated, and no pallor, jaundice, clubbing, cyanosis, pedal edema, engorged neck veins, or generalized lymphadenopathy or left supraclavicular lymph node. Secondary sexual characteristics present. And vital signs are as follows: pulse of 78 beats per minute in the right radial artery, with a blood pressure of 110/70 millimeters of mercury, with a respiratory rate of 15 per minute, and a febrile. On local examination, both breasts looks symmetrically enlarged, and nipple areolar complex in both breasts looks normal. On palpation, there is moderate enlargement of both breasts. I classified it as Simon Group B. Bilateral breast disc palpable and mobile. It is free from skin and underlying pectoral muscle. Skin over the breast, nipple, and areola are normal, and no palpable lymph nodes in the axilla. On systemic examination, there is no organomegaly and no other palpable mass parabdominal. External genitalia is normal, and other systemic examination are also within normal limits. I summarize as follows: a 17-year-old presented with a bilateral. Pardon, sir?
No, carry on.
The 17-year-old presented with a bilateral enlargement of both breasts gradually over the last 1 year. There is no history of rapid increase and no discharge from the nipple. On general survey is essentially normal. On examination, there is symmetrical enlargement of both breasts. On palpation, there is moderate enlargement of both breasts noted. Bilateral breast disc palpable and mobile. It is free from skin, underlying pectoral muscle, and skin over the breast, nipple, areola are all normal. No palpable lymph nodes in the axilla, no hepatomegaly, and both testes are normally palpable. I provisionally diagnosed this as a case of bilateral gynecomastia in a 17-year-old male. Thank you, sir.
So, Ishita,
Yes, sir.
how do you define gynecomastia?
Sir, it is bilateral. It is enlargement of breast tissue, similar to that of a female breast.
It's benign condition, isn't it?
Yes, sir.
So you add it is a benign enlargement
of the breasts, which
breast, male breast tissue,
male
glandular tissue,
which resembles a female breast.
Yes. And is there any criteria, cutoff limit, like the breast disc you talked about? Is there any cutoff limit as far as the definition goes?
Sir, 2 centimeters, sir.
Yeah, then you should have mentioned it in your findings, physical examination findings, that I could feel a disc of retroareolar disc of breast tissue, which is more than around 3 centimeters in size or whatever, isn't it?
Okay, sir.
Well,
Yes.
that will fit into your diagnosis better.
Okay, sir.
Why does it occur, basically? Why does it occur?
Sir, gynecomastia.
Yeah.
Sir, it can occur due to increase in estrogen in the body and decrease in testosterone. And when there is when increased peripheral conversion of estrogen and decreased metabolism of estrogen.
That means imbalance. There is an imbalance
sir.
between the estrogen and the testosterone level.
Yes.
Either absolute or relative increase in the estrogen level in the body, isn't it?
Yes, sir.
And how do you classify gynecomastia?
One question on the clinical part. One question. Ishita, in general, sir, you said Karnofsky is 100.
Yes, sir.
What do you mean 100 Karnofsky?
Sir, the patient is absolutely fit, sir.
Absolutely fit.
Yes, sir.
Why he came to you?
Sir, he came with
bilateral breast enlargement.
Yes, sir.
Bilateral so he has minor symptoms of the disease. Try to understand. Okay. If it is 100 mean asymptomatic stage of the disease. Okay. When the patient comes to you with breast enlargement, he may not have pain, but he has this group as minor symptoms. It should be 90. Okay. 100 is described as asymptomatic stage of the disease. That is, patient has no symptom, patient has no restriction. So 90 also he is otherwise fit.
Yes, sir.
Karnofsky 90 means he can do his activities.
Yes.
Normal activities, and he has minor symptoms. So he should be 90. 100 is high. Fine. Okay. The next part, Dr. What should I ask you?
Sir, gynecomastia is graded according to Simon's scoring.
No, not grading. Cause-wise, how do you classify it?
Sir, pseudo-gynecomastia and true gynecomastia.
Yeah.
Is it this what you were asking for?
What are the other ways of classifying?
That will come into the differential diagnosis, whether it is a pseudo-gynecomastia or true gynecomastia, or it is a breast carcinoma, whatever. Now, how do you classify it? It is classified as either physiological or
physiological senescence. Physiological and
or pathological.
Pathological, and physiological is neonatal, pubertal, and senescent.
What is the cause of neonatal gynecomastia?
Sir, it is because of the maternal estrogen, which comes to the placenta, and it subsides usually by 3 to 4 weeks.
Very good. And adolescence gynecomastia?
Sir, adolescence, it is due to the
cause, pathophysiology.
It is due to the decrease in testosterone and increase in estrogen, or it may
basically
be
imbalance. Again, basically imbalance.
Yes, sir.
What is the natural history of pubertal adolescent gynecomastia? Natural history?
Means the hormones responsible.
No. Natural.
How it behaves?
So, if there is increased fibroadenoma and scattered ducts.
Okay, if you follow this patient, what is going to happen?
So there is an abrupt increase in the size of the breast.
Suppose you
Gynecomastia
don't
has developed.
intervene.
Now, if you don't intervene, what will happen to this patient? If you
So
don't, natural history means
it
a
will
course of the
subside.
disease without any intervention.
Yes, sir. It may subside with time, sir. In about 2 years, 1 or 2 years.
Yes, in 2 to 3 years, most of the adolescent gynecomastia regresses.
Yes.
That is very high, maybe 40 to 70% can regress spontaneously. That is the natural history. Yes.
And third was the third one is neonatal, you said, then adolescence and finally senescence. As far as your case goes, what is the atypical feature of this particular gynecomastia you talked about, this adolescent gynecomastia?
Sir, he does not have obesity, but he is having.
Usually the adolescent gynecomastia is unilateral, while senescent gynecomastia is bilateral. In your case, it is a bilateral disease, isn't it?
Okay, sir.
Understood?
Yes, sir.
The one you talked about, the case that you presented here is having a bilateral swelling. Usually the adolescent gynecomastia is unilateral and senescence is bilateral.
Okay.
All right. Okay, then you talked something about the pseudogynecomastia that comes into the different. What is the pseudogynecomastia?
Sir, pseudogynecomastia is generally composed of increased fat due to obesity.
Without any increase,
without any fibrous. Yes, sir. Without any fibrous stoma.
Yes, it can be granular also. Try to understand. It's not always fibrous. In gynecomastia, there is a mixed component of fibrous, fatty, and stromal and glandular enlargement. It's a combination.
Okay.
But in pseudogynecomastia, it is only the fat. Okay. And you had mentioned certain things that by which you tried to exclude breast carcinoma. So what are the features of a carcinoma breast, which will also be a part of your differential diagnosis?
Sir, there is gradual progress of the disease, and
age-wise, it doesn't fit into the case of a carcinoma breast. Number one, yes. Male breast,
and gradual increase, sir. And there is no family history. And no. Pardon, sir?
No, say disturbance. Just carry on.
Okay. Sir,
what are the other features which exclude is not a malignancy?
Sir, then there is no adherence to the swelling, or there is no adherence to the skin or underlying muscle.
No nipple skin changes.
No changes over the skin areola, and no nipple retraction.
The disc appears smooth.
Disc appears smooth, sir.
And absolutely symmetrically below
symmetrical enlargement, yes.
Below the what do you call areola. Usually breast carcinoma will have an eccentric sort of a swelling which is very hard and fixed and with overlying skin changes, isn't it?
Yes, sir.
Does it increase does this predispose this patient of yours to increased risk of breast carcinoma?
No, sir. From gynecomastia, there is it's very rare, sir, to progress it to carcinoma, sir.
Carcinoma. Very good. So usually does not predispose to breast carcinoma, except there is one exception. What is that?
Sir, there can be other carcinomas related to gynecomastia.
No. Which type of gynecomastia can predispose an individual to develop breast carcinoma later on?
Unilateral.
Any genetically inherited condition?
Sir, BRCA2, sir. BRCA2 mutations in the family.
No. If it is associated with Klinefelter syndrome, that is XXY. Okay, sometimes Klinefelter syndrome is associated with gynecomastia, and those cases are at increased risk of developing breast carcinoma. Okay, now you are talking about grading, Simon's grade. How do you grade the gynecomastia?
Sir, Simon's, according to Simon's grading, sir, so there will be mild breast enlargement is classified as group 1, And sir, then group 2
Mild
is,
enlargement without skin redundancy.
mild enlargement without skin
No
redundancy.
skin changes.
And group 2A is moderate enlargement of the breast without skin redundancy. And
Yes.
group 2B is moderate enlargement of the breast with skin redundancy.
Mild.
Very
And,
good.
and the group 3 is enlargement, a severe enlargement with skin
Marked.
redundancy.
Marked enlargement
Marked
with-
enlargement with
And
skin
breast is
redundancy.
ptotic.
and ptosis.
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 Yes, sir.
Very good. Can you tell us about, you had talked about the various predisposing, you had excluded from the history the various other predisposing factors which can lead to development of gynecomastia. So can you summarize what are the causes which of different conditions which can predispose to develop an individual to develop gynecomastia?
Sir, there can be, sir, disease related, sir, as in chronic liver failure and predispose after mumps orchitis. And it can be drug related, sir. It's like anti-tubercular drug like isoniazid, cimetidine, and then thiazides and spironolactone. And
Apart from myocarditis, the basic term should be hypogonadism.
hypogonadism.
Hypogonadism for any reason. There are a lot of other reasons which can cause like testicular anorchia, okay, testicular atrophy because of other reasons like torsion, anything. It's a condition hypogonadism.
Maybe primary hypogonadism or
That is
secondary hypogonadism?
acquired, sir.
Yes, acquired maybe like from trauma, mumps orchitis, even castration. If you just remove the testis, okay, then cryptorchidism.
Yes.
These are all causes of primary
Hypogonadism.
Yeah.
And Klinefelter's as well, sir.
And
Klinefelter.
any adrenal lesion.
Any adrenal lesion, sir.
Feminizing tumor in the adrenal.
And, yes, sir. And sir, testicular tumors also. Sir, Leydig cell tumors or Sertoli cell tumor can also give rise to gynecomastia.
And some lung conditions like.
Sir, lung condition.
Not the patient, but in elderly patient, some bronchogenic carcinoma.
Bronchogenic carcinoma.
Because this is a paraneoplastic syndrome.
And sir, chronic renal failure and hyperthyroidism also predisposes to gynecomastia.
What is that element which is responsible for gynecomastia in case of, say, bronchogenic carcinoma or testicular, as you said, tumors?
Sir, the human serum binding album, human serum binding.
No, HCG, human chorionic gonadotropin. That is the element which is secreted. Like in bronchogenic carcinoma, also in paraneoplastic syndrome, these are secreted. Similarly, in testicular tumors, as you talked about, the chorionic teratomas. There are different types of teratomas. So they can secrete HCG, and that may be responsible for.
HCG, and also you said Sertoli cell tumor, which secrete estrogens straight away.
Yes. And what is the cause of senescence gynecomastia? That in around 50 to 70 years age group, many patients develop gynecomastia. What is the cause of that?
Sir, it is due to peripheral aromatization, sir, of estrogen.
No, that is mainly in patients with obesity, gross obesity. The peripheral aromatization causes increased estrogen level. And what
happens in aging? What happens in what hormonal changes occurs in aging?
Testosterone.
Yes.
Decreased testosterone.
Androstenedione and
dihydrostenedione.
Yes, these are going to the lower level, and relative it may not
rise
be increased state. It's a relative rise of estrogen.
Yes, relative rise in that. And there is also another element which occurs here. There is a increase in the testosterone binding globuli. So whatever testosterone, as it is, the testosterone is low, and now the
whatever free testosterone level comes down.
Very good. The free testosterone level comes down. Okay. So you have also talked about different pharmacological agents which can cause gynecomastia. Sometimes, you know, the bodybuilders who, you know, going for these
anabolic steroids, sir.
Yes, anabolic steroids. And these people also know that you can counteract that effect of anabolic steroids with some another drug. You know that? What is that drug?
Sir, danazol.
Yes. No. Anything else? Tamoxifen. So these people, they know that taking anabolic steroids can cause gynecomastia. So they also start taking testosterone or what do you call it?
Tamoxifen 10
Tamoxifen.
milligram twice.
Yes, along with it. All right. Now we can come to the treatment part. So how do you approach this patient? One thing sir has already told you, that we can simply wait and watch. Many of the cases will resolve on its own about over a period of 2 to 3 years, isn't it?
Yes, yes, sir.
So how do you counsel the patient? If you say you cannot just send him back from OPD saying go home, nothing to be done. So how to counsel the patient?
Sir, in any case of breast, we'll go ahead with the triple assessment, sir. Sir, we'll after clinical examination, we'll like to go for one radiological investigation.
Like in this patient, what do you want?
Ultrasound of the breast, sir, with bilateral axilla.
Then when you say
pardon?
triple assessment with FNA is not recorded in this patient.
Yes,
Patient
sir.
has been clean, gynecomastia, if he readily fitting into the smooth enlargement of the breast, they don't go for a confirmation by doing a biopsy. That is indicated in suspicious lesions. If you have a suspicion that there is another hard firm swelling which is suspicious, particularly in elderly patient, then otherwise in a pivotal gynecomastia, a triple assessment with biopsy is not required.
And sir, after this, we will reassure the patient that
how? Tell me what sentence you use to reassure him.
Sir, I will like to explain the patient and his parents that this is a pubertal. This is
physiological.
Physiological, yes, physiological thing, and it may subside in 2 to 3 years. But we have to be he has to be aware that he may be bullied and counseled accordingly to not get.
He may have fear of cancer. He heard that enlargement means possibility of cancer also. So you have to address this. Okay. This is not a something called to be as tumor, and there is no risk that it will turn into a tumor and will harm him. So these are the important things. You see, counseling is also now coming as a big part of your examination. So you have to explain this. This is not going to harm him. There is no possibility it will turn into tumor, and there is no possibility it will spread to other sites. And most important is, if you wait and watch, this may regress without any treatment. Okay, so that is the most important part of your management.
Okay.
Now the patient has come back to you after 2 years. The thing has not resolved spontaneously, because all cases are not going to resolve spontaneously. So,
or he is cosmetically not accepting the situation.
Cosmetically not accepting.
He is in a school and then he's being bullied and he wants some relief from this. What are the ways?
Options.
Sir, I'll go. So first I'll wait for the skeletal maturity till 22 to 25 years, and then only I will like to go for any operative intervention.
No. He's 17 years. You cannot send him home for 8 years that he'll come back to you with this gynecomastia problem. There are some other measures. There are some measures which can help in reduction of this gynecomastia.
Sir, we will go for liposuction, sir, or subcutaneous mastectomy.
That means straight away intervention.
Straight away intervention. No. Any other medical management?
Yes.
So
tamoxifen. We will give tamoxifen, sir.
What are the drugs? What basically is, you already said, is the imbalance between the androgen and the estrogen.
Yes, sir.
So you need to alter this milieu.
Balance. Yes, sir. So then I'll like to give sir tamoxifen, and or we can give danazol, sir.
And he'll go to a chemist shop. Somebody will say, what happened? Is a cancer
Or
drug. You are
cancer
taking this
drug.
drug. So how do you counsel this patient? Because tamoxifen, any chemist will say is a cancer drug.
So that is selective estrogen receptor modulator. So we will
No. How do
explain
you
to the
counsel
patient.
the patient before sir is asking?
So we will reassure the patient that this is an anti-cancer drug, but it is still used because means the mechanism is to increase the estrogen
Yes.
receptor.
So if you prescribe tamoxifen even for benign breast in females also, that counseling has to be done. That your basic disease is because of some hormonal imbalance, and you are prescribing a drug, although this is being used for some tumorous condition in the breast, but this drug we are giving for you for changing your hormonal milieu.
Hormonal activity.
Yeah.
So danazole, tamoxifen, any other thing? Especially, say, for example, not in this particular age group, but in patients with senescence gynecomastia, any other with obesity?
Metformin.
No. For gynecomastia, once you have uttered also aromatase inhibitors.
Yes, aromatic.
Yes, where peripheral conversion is taken
In
care
elderly,
of.
this is an important explanation. In elderly patient, there is increased peripheral conversion of estrogen. So this aromatase inhibitor will inhibit adrenal conversion to estrogen and peripheral adipose tissue conversion. So aromatase inhibitor is another important drug, like anastrozole.
Testosterone is another, I think, aromatase inhibitor that
yeah, testosterone, yes.
Testosterone. Okay, so these are the drugs: tamoxifen, danazole, anastrozole, aromatase inhibitors, and then comes the other the final part of the treatment. I think the other option, that is operative option, when there is a failure of medical management or the patient still complains of increase in the size. In that case, you have to go for some intervention. What are the different?
So if we give medical management and wait for about 6 months to 1 year, if it fails to regress, then we will like to go for operative intervention. And so
what is the minimal operative intervention? Minimal operative intervention.
So it is liposuction, sir.
Yes. Where liposuction will be more effective?
So in grade 1 means when there is no skin redundancy, sir.
And it is, you see, the gynecomastia is a combination. In pseudogynecomastia, it is only the fat. So pseudogynecomastia, weight reduction and other measures can cause regression. And in gynecomastia, where the fatty component is more, you have stomal other enlargement. If the fatty content is more, then only liposuction may be effective. But once there is more enlargement of the breast disc, then patient will require some other adjunct treatment along with the liposuction.
Liposuction.
Yes, sir.
So you have to combine the excision of the breast disc along with liposuction. Liposuction for the fat, and then you can that way you can reduce the size of your incision also. The things will be smaller. Just remove the
periareolar incision. We can approach it.
Yeah. Yes, you can remove the breast disc. So combination of liposuction with surgery, isn't it?
Yes,
what is the problem with liposuction? And there is a problem also with liposuction.
Sir, it will be fat necrosis, sir.
Yeah, fat necrosis. Basically, you are removing the fat by suction, but it can cause some cosmetic, since there is a redundancy of the skin in certain cases, and you are removing the entire subcutaneous fat, there may be a deformity, disc-like deformity on the chest wall after removal of that the underlying fat. Understood?
Yes, sir.
That is one cosmetic problem. Is there any other question?
No, I think we can pass on to the next case. We kept two cases.
Just a passing question to you. Can a prolactinoma lead to gynecomastia?
So prolactinoma will cause a galactocele type feeling.
Very good.
So
galactorrhea, but not a gynecomastia. Very good.
Okay, Ishita, you are ready for the next case?
Yes, sir.
Pass on.
Sir, is it visible, sir?
Yes, yes. Slideshow. Carry on, please.
Yes, sir. So Miss Y, a 17-year-old college student, resident of Kolkata, presented with a lump in her right breast for 2 years. On history of present illness, the patient was apparently well 2 years back when she noticed 1 × 1 centimeter size swelling while bathing, which has gradually progressed to the present size of about 3 × 3 centimeter in the upper outer quadrant. No history of rapid increase, no history of discharge from the nipple, no history of swelling in the opposite breast and axilla, no history of pain, and no relation of pain with the menstrual cycle, no history of swelling in the axilla. History of past illness, no significant illness, no history of exposure to tuberculosis, and no comorbidities. Sleep, bowel, bladder, appetite are all normal. No history of any allergy to any known drug or food. She has achieved a menarche at the age of 11 years, and since then, her cycles has been regular and with an adequate flow. And no similar disease to any other members in the family. I summarize it as a 17-year-old lady presented with a swelling in her right breast for last 2 years. It was 1 × 1 centimeter in size at the onset, which has gradually progressed to the present size of about 3 × 3 centimeter. No history of rapid increase, no history of discharge from the nipple, and no other swelling in the opposite breast and axilla. On general survey,
You go back 2 slides. Yeah. No, one more slide. Another slide. Yeah. No history of what you mentioned about the family history somewhere.
yes, sir.
Where is it? No similar disease on to any other members of the family. Means
Yes.
you had excluded the possibility of similar disease or other breast conditions like breast malignancy as well. History of breast cancer in the family.
So history
That-
of sir, according to the history with this is a means I suspect it to be some benign lesions. So I have
No,
just
that is
asked.
all right, but you should mention that there is no family history of breast cancer because that has got some relation.
Actually, Ishita, you
treatment.
keep in mind that when you are presenting, while presenting, you have done the complete part, history and examination. So once you have a swelling in the breast like this, and at the end you have an impression it's likely to be fibroadenoma, then is no point mentioning there is no history of fibroadenoma in the family. What is more important is we are interested to know whether this patient family has some breast ailment which is malignancy
sinister.
or any other malignancy which will arouse some suspicion in this patient.
Yes.
Because of this lump. But clinically, once you come to fibroadenoma, then there is no point saying no history of fibroadenomas in the family. Because fibroadenoma is not having a definite genetic link. Okay. Examination.
So here also I shall mention, sir, the Karnofsky score as 90, sir.
Yeah, you should be. Because she has some symptoms. This is minor symptoms.
Okay. And my general examination is essentially normal. On local examination, both breast looks normal in position and symmetry. Nipple areolar complex in both breast looks normal. On the right breast, no visible swelling noted and no venous prominence. On palpation, left breast is normal and right breast is 3 × 3 centimeter lump noted in the upper outer quadrant, globular in shape, well-defined margins, firm in consistency, smooth surface and not fixed to skin or underlying structures. The lump is very much mobile in relation to the breast tissue. It slips under the finger as pressed, and no palpable lymph nodes in the axilla. Other general examination is normal. I summarize it as a 17-year-old female presented with a swelling in her right breast for last 2 years. It was 1 × 1 centimeter size at onset, which has gradually progressed to the present size of about 3 × 3 centimeter. no history of rapid increase, no discharge from the nipple, no other swelling in the opposite breast and axilla. On general survey, it is essentially normal. On local examination, 3 cross 3 centimeter lump noted in the upper outer quadrant of the right breast, globular in shape, well-defined margins, firm in consistency, smooth surface, not fixed to skin or underlying structures. The lump is very much mobile in relation to the breast tissue, slips as under the fingers as pressed, and no other swelling in the same breast, and no other swelling felt in the opposite breast or axilla. I provisionally diagnosed this as a case of fibroadenoma right breast in a 17-year-old female.
What are
Thank
the
you.
points in favor of your diagnosis?
Sir, points in favor is the age group, sir. It is between 15 to 25 years, and it is a smooth swelling.
What is the importance of that age bracket, 15 to 25 years?
Sir, here we generally get means abnormal development. Means,
Why abnormal? This is not abnormal. It is the early reproductive
the aberration in normal development and involution. It comes.
Yes,
The disease spectrum comes in this age group.
Yeah, normally there is lobular development, and as a disorder, sometimes some patients can develop the hyperplasia of the lobular component of a particular lobule, and that leads to the development of fibroid. Okay, number one, that is the age group. Next.
Sir, it is a smooth swelling, and it has it is a small swelling which has gradually progressed over 2 years. There is no rapid increase, and it is margins are smooth and smooth surface and well-defined margins.
Usually, fibroadenoma has got a slightly lobulated surface. Anyway, then.
And
Next.
Mobility.
Yes, sir.
Highly
mobility,
mobile.
It is highly mobile.
That is the most important thing. Yeah.
It's like a breast mouse.
Like a breast mouse. So basically, what is a fibroadenoma? Can you tell us about that? What is a fibroadenoma?
Sir, it is diffuse enlargement of a part of lactiferous ducts, sir.
No.
Lactiferous duct is
aberration
close
of
to the nipple. Lactiferous ducts are close to the nipple and just little way, but you may have fibroadenoma in the peripheral part of the breast also, where the lactiferous duct does not form. What it is actually? It's a benign tumor.
It is a benign tumor, sir.
Are you sure?
Yes, sir. Yes, sir.
No.
Can
if you say ANDI,
fibroadenoma be a normal finding in the breast?
ANDI is not a situation where you term this benign tumor. Fibroadenoma is an aberration in normal development involution, where you have more proliferation of the glandular tissue.
Then the fibrous.
It is not classically described as benign tumor.
Okay. We shall bring it as in the disease spectrum of ND.
Yes.
Yeah, it is basically an aberration of normal development. Involution has not yet started. It is a normal aberration of normal development. It is characterized by the hyperplasia of both the epithelial and the stromal components of a lobule, isn't it? Because of increased sensitivity of that particular lobule to the, it is hormonal sensitive, isn't it? It is very sensitive to the, you can say that the focal area is more sensitive to estrogen. That's why there is hyperplasia of these components, isn't it?
Yes, sir.
Okay. So, so this is not a, as I said, this is not a disease. This is characterized as an aberration or a disorder, isn't it? What is when the thing becomes? When does the thing become a disease?
Sir, when it grows, when there is a rapid increase in size, when it grows to about more than 5 centimeters, when it causes pain for the patient.
Either it is becoming more than 5 centimeters in size, that is giant fibroadenoma, or there are multiple fibroadenomas in a particular one breast. Understood? So that becomes a disease. Otherwise, it is a disorder, you can say, or an aberration. So
any DD on this patient? Any differential diagnosis?
Yes.
No, I will like to keep my differential diagnosis as a breast cyst or
Yes.
breast cyst and antibioma. and traumatic hematoma, sir. Hematoma or traumatic fat necrosis.
Okay.
But there is no history of trauma, so
Yes.
I rule out that, and there is no history of any fever.
Can it be a nodule in the background of fibroadenosis?
Yes, sir, it may be present as well.
Point against?
Sir, fibroadenosis is a diffuse swelling with
Usually associated with mastalgia. You said this patient does not have any mastalgia.
usually associated with mastalgia.
Fibroadenosis is
Cyclical
nodule,
mastalgia.
yeah, with nodularity, and these nodules are usually not of the size of 3 centimeter, little
Less, sir.
less.
And fibroadenosis is also seen in a little later part of the reproductive age group, isn't it?
Yes, sir, at around 30 to 45 years.
Yeah, the next age bracket, that is around 25 to 40 years age group, that is the age group for fibroadenosis. All right, how do you like to investigate?
Sir, I will like to, sir, I'll go for a triple assessment, sir. After clinical examination, I will like to go for a radiological examination. In this patient, I'll like to go for a bilateral ultrasound with axilla.
Tell me the character. What is the ultrasound characteristics of a fibroadenoma lesion?
It is a well-defined lesion.
One.
It has no posterior acoustic shadow, regular margins, and halo around the lesion.
Taller and wider?
Sir,
Yes.
yes, the anteroposterior diameter is less than transverse diameter.
Yes,
It
wider
is
than taller.
broader than taller, and the anteroposterior diameter is less as compared to the other differential diagnosis. You can say that there is a phylloid tumor where the
How to
anteroposterior diameter
differentiate?
is quite.
What is the special feature of a phylloid tumor on ultrasonography?
Sir, there
That
will
is
be
also benign.
leaf-like pattern, sir. So there will
Yes.
be leaf-like
So
pattern.
the outside
the
picture may be identical, but if you see closely, there will be cleft-like cleavages inside this lesion, which may suggest is a phylloid tumor. Okay, so suppose you find 3-sided lumps, classically fibroadenoma, will you go for TrueCut or will you go for FNA?
Sir, I will like to go for TrueCut biopsy, sir.
You see, that, now people are saying that this is an area where you can consider doing FNA because it is a classic fibroadenoma with clinically and imaging. There is no suspicion of malignancy. Just for confirmation, just FNA may be
Sufficient.
sufficient. Because
What are the indications for core needle biopsy? Can you tell us what are the indications for core needle biopsy?
Sir, any suspicious lesion is
No, in a apparently benign breast lump, as sir said, the FNA is the for psychological diagnosis is more. Is what is indicated, but there are certain indications where you should go for a core biopsy. What are those?
So when our FNA findings and clinical findings are there is a mismatch.
Okay.
And
yes, very good. So
and the lady is around.
And the elderly lady, postmenopausal, and sir, to determine
from the history, if there is a history of sudden increase in the size, rapid increase in the size rather, and in a long-standing breast lump, benign breast lump, if the swelling is more than 3 centimeters, the age of the patient is more than 35 years, that is from the history. And then, as I said, if in imaging, ultrasonography, you are finding cystic areas within a solid mass. Okay, understood. And yes. On cytology, if you are finding, if you have got features like hypercellular sort of a stroma
and irregular margins, a distorted architecture,
cellular pleomorphism, and all those features are there, then you should go for a core needle biopsy. Understood. These are the indications. Clear-cut indications are there when you go for core needle biopsy as against FNA.
What is the natural history of fibroadenomas?
Sir, it may regress, sir, within 2-3 years. And
what is the percentage?
What is the percentage? Yes. What is the
He
percentage?
said you may. I may use the term it might.
Sir, percentage, I'm afraid, sir, I don't
Very
know.
high. Almost 80-90% fibroadenoma regress continuously. So you understand that again, like gynecomastia, this is not a situation that you always
Go for
advise
intervention.
active treatment. Okay, there is a situation that you can consider wait and watch policy.
So to continue with the natural history, suppose you don't operate, but there is also a percentage, quite a good percentage of cases where it will not regress and it will remain static. Okay, there is a percentage of cases around 10% or so where it will increase in size. As I said, a handsome percentage of the cases will remain static, but there will be also a percentage of cases where it will increase in size. Suppose you are following this patient up and the patient is not, it is not regressing, but how will the character vary as the patient gets older?
It will
You
be
got my question?
Sir, it will be accompanied with more fibrocystic changes around it.
Yes, it will be accompanied by fibrosis of the stroma. So the mobility that was there in the younger age, that will get reduced over a period of time because of the fibrosis of the stroma. All right. And component of involution will also set in. So long it was the development, aberration of development. Now the things will start involuting. Okay, and there may be features of calcium. It becomes slightly harder, and on imaging you can find some calcification. That is called popcorn calcification in case of fibroid. All right. Next, I was asking you something.
Yes. So a patient is anxious that she has anxiety about the tumors, and then she is in constant anxiety about this tumor. What should be your approach? You have done triple assessment. You have diagnosed this is a benign lesion, fibroadenoma, but patient is very anxious.
Sir, I will again go for counseling, reassurance of the patient, and counsel the patient that this is a benign tumor, and the chances of malignancy from this is means almost nil. It is less than 0.2%. So the patient may not be anxious about it. And if I'll ask the patient to follow us in the outdoor in every 3 months. And if there is any rapid increase in size and painful or ulceration, then to come immediately for treatment.
Yeah. So for as far as observation goes, okay, if a fibroadenoma is within 1 to 2 centimeter size, usually they regress. Okay, but if a fibroadenoma becomes more than 2 centimeter, as in your particular case, that is 3 centimeter, it is unlikely
borderline situation. 3 centimeter is again a borderline situation.
Borderline situation. So it is unlikely to regress on its own. You can say that you can keep it under watch for some time, but it is unlikely to resolve. In those cases, what are the options? Young guy, a young girl doesn't want too much of scarring on the breast. So any other options that are available for lesions which are around 3 centimeter or more?
Vacuum assisted biopsy.
So, you see now in the literature you have a lot of reports of some drugs being effective in regression of fibroadenomas. This is now is not in textbook yet, but it is there are a lot of publications now saying that efficacy of some drugs in fibroadenomas, like
vitamin E. Vitamin E
is 0. Vitamin E is out from benign breast disease. Vitamin E is out. Primrose oil is out.
Oh.
Any other drug? There is a lot of number of reports come. One important drug is ormelifixin. Okay, so this is again a anti-estrogen drug. This blocks the estrogen receptors. So again, the fibroadenomas and all these benign breast disease which are happening because of imbalance of
hormones, estrogen.
Relative increase in estrogenic activity. So there are some reports that this ormelifixin. So how do you give? What is the dose of ormelifixin in this group of patient? How do you administer?
Sir, I don't know, sir.
You don't know. So it's
30
milligram
twice weekly.
It's 30 milligram given alternate day thrice a
or
week.
60 milligram twice weekly.
Yeah.
Yeah, twice weekly.
Okay. So
Either
you
60
can,
milligram twice weekly or 30 milligram on
Twice
alternate
weekly.
basis.
yeah.
Alternative day. Okay.
Yes, you can give this patient this for about 2 to 3 months, and most of the time it is seen that there is higher incidence of regression of fibroadenomas with this ornamentation. Some people have also tried danazol, but danazol has got a lot of side effects in the form of hirsutism, fluid retention, acne. So it has got a lot of androgenic effect. Okay. So these are the two important drugs which have been used, and again the tamoxifen. Tamoxifen is also used, but tamoxifen being a antineoplastic drug is not being prescribed for fibromas, where you have more incidence of regression of natural regression. Okay, and again 3 centimeters is a borderline group. If the patient is anxious and she doesn't want to keep it, one indication for surgery is
The cosmetic reason.
you have not seen this lump from outside as a doctor. You said breast is normal. So what is cosmetic problem? In this patient, the breast was symmetric. You see, here there is no cosmetic issue. The lump is not seen.
Okay.
There is no change in symmetry of the breast. On inspection, nothing was seen in the breast. So it's not cosmetic issue here. Here, the issue is anxiety.
Anxiety.
That she has got a lump in the breast, she could palpate. So one indication for surgery is patient choice. If the patient does not want to continue with your reassurance or some drugs, there is one indication, then you can remove, because anxiety is one important factor in such breast lumps.
So patient is very anxious, wants the thing to be removed, but at the same time, she is very anxious that she shouldn't get any minimum scarring of the breast, minimum scar. So what are the options to use? In a lump, in a fibroadenoma, which is around 3 centimeters size.
So we can go for vacuum-assisted biopsy, or
yes,
radio
ultrasound guided vacuum assisted biopsy, UGVAB as it is called. Number one. Number two,
and
what does it do? It is causes. What does it do?
So it means it
causes basically peeling off.
Stroma it gets
peeled off
liquefied.
Gradually. Yeah, peeled off. Next is,
it is not just really a biopsy specimen. In these biopsy and fibroadenoma, you take the whole tissue out.
Fat cells are sucked in.
Yes.
Okay. Any other options?
The cryoablation, sir.
Cryoablation. Any other thing?
And so radio frequency ablation.
Without any radio frequency ablation. Very good. That uses the what does it use?
Alternate current, sir. AC current.
Thermal, basically thermal ablation.
High frequency alternate current.
Yeah, thermal ablation of the fibroadenoma by percutaneously placed radio frequency probe.
There is a chapter in recent advance. You see, there is a chapter in recent advance for management of benign breast disease. I think it is 37 or 38. There is a good chapter on benign breast disease and its different modalities of treatment. Everyone should read that chapter.
And if she doesn't want any scar at all, no scarring, any other option that is, but wants the tumor to be removed.
So we can go for enucleation through periareolar approach.
No scarring, not even a minimum scar, but still she wants the thing to be removed. Any option, size around 3 centimeters. What is ecotherapy? You know about ecotherapy?
No, sir.
No, it is high intensity focal ultrasound that can also cause, as like in case of radio frequency ablation, it can cause the ablation of the tumor. This is also called HIFU, HIFU, high intensity focal ultrasound or ecotherapy. So no scarring. It is done from outside the breast. The ultrasound, the waves are focused onto the particular lesion. So what are these? So one is observation, 1 to 2 centimeter. You just simply observe, likely to resolve. Second is around 2 to 3 centimeter size. You can go for minimally invasive procedures like cryoablation, radio frequency ablation, high frequency USG ablation, and this vacuum assisted biopsy. And final is the surgical removal, usually for lesions which are more than 3 centimeters in size. So can you now summarize what are the indications for surgery? One I told you just now, more than 3 centimeters in size.
More than 3 centimeters.
Sir has already said that
rapid increase.
Patient wants surgery.
And sir, and rapid increase and any cosmetic concern.
No. Rapid increase here, that will be, I mean, the clear-cut indications will be more than 3 centimeters. Patient wishes, number one. Patient is more than 30 years of age. The size of the tumor is more than 3 centimeters. As you said, that the cytology is discordant, somewhat not fitting into the clear-cut diagnosis of fibroadenoma, and you are still working it up with further, investigation like core needle biopsy, and again that is going in not exactly in favor of an fibroadenoma. There you have to again go for excision. And if the patient is having a family history of breast cancer, here comes the what you call importance of noting that whether the patient is having a family history of breast cancer. That is very important. So family history of breast cancer, and there is another entity which is called a complex fibroadenoma. Can you tell us what is a complex fibroadenoma?
Sir, it is a juvenile fibroadenoma.
No, that is juvenile fibroadenoma is different. Juvenile fibroadenoma is different. What is a complex fibroadenoma?
So more of glandular component than fibrous component in the lesion.
If you get cysts within that lesion, cysts, some epithelial calcification or papillary changes on core needle biopsy, that will be characterized as complex fibroadenoma. So especially these complex fibroadenomas have got increased risk of breast malignancy, 3 to 4 times more chances of getting converted to breast cancers. So that needs to be surgically removed. Okay. So these are the clear-cut indications of the treatment modalities. Understood?
What is the difference between enucleation and excision?
So enucleation, we leave the capsule behind, sir. We just take out the lesion when leaving the capsule, and excision is we take out the capsule with a margin of the tissue.
Just outside the capsule. You don't need to get wide margin of the normal tissue in fibroadenoma. Okay, if you have suspicion of Phyllodes tumor, you use the excision outside the capsule
also.
1 centimeter margin you should take all around if you are suspecting a phyllodes. And if it is a clear-cut case of fibroadenoma, we go for enucleation. I think so. We have covered most of the.
Yes. These are the usual questions. You should first of all is your approach. You take a good history, do the proper examination, and then try to give a good summary and the diagnosis. Okay, it's a case of fibro on the right breast in a 70-year-old girl. Okay.
And the definition of giant fibroadenoma is also somewhat controversial. Like in some most of the cases, it said more than 5 centimeter. If you go to Schwartz, it is said if it is more than 3 centimeter, that is characterized. Schwartz says more than 3 centimeter. Other books says more than 5 centimeter. Now it is a little bit of a controversy, we should say.
Okay, sir.
Thank you very much.
Thank you, sir. Thank you.
Thank you, Ishita. Nice presentation. Good.